Welcome to the American Physiological Society Living History of Physiology program. I am Ed Zambrowski. I am an emeritus professor of physiology at Rutgers University. Currently, I am the division chief of the Military Performance Division at the U.S. Army Research Institute of Environmental Medicine in Natick, Massachusetts. In 2005, the American Physiological Society began the Living History Project. The concept was to establish archival video interviews of eminent senior physiologists who have made outstanding and impacting contributions towards the advancement of physiology, as well as in their own areas of research. The intent of the program is to capture some of their research contributions, as well as their experiences in terms of a career as a research physiologist. Today, it is my pleasure and honor to interview Dr. Charles Tipton. Dr. Tipton is an emeritus professor of physiology from the University of Arizona. Dr. Tipton is an exercise physiologist. As we will discuss, he has worked in a wide variety of areas, published over 150 refereed manuscripts, and edited several and contributed to many books. Over a 21-year period, he established a nationally renowned PhD training program at the University of Iowa before relocating to the University of Arizona. Dr. Tipton is also past president of the American College of Sports Medicine. He has been in leadership roles within the American Physiological Society and has received several major awards from the APS for his research and professional activities. As one of his PhD students, I consider it a privilege to be asked by the American Physiological Society to interview Dr. Tipton. Tip, welcome. Tip, can you give us some idea of your background, where you grew up, your education, and how you got interested in exercise physiology?
Yeah, I'll be pleased to, but first of all, I want to thank you for coming. It's a pleasure to have you here in Arizona. I grew up in rural Maryland, close to D.C., approximately 30 miles, and also close to Leesburg, Virginia, approximately the same distance. It was during the war years, and actually I became interested in physical education because during the war I had the opportunity to lead many classes in calisthenics. I enlisted in the Army Reserves, and after the war I entered the Army, and fortunately I was able to become a physical training instructor within the Army, and subsequently not only here in the States, but when I went to abroad in Japan with the 25th Division. After I returned from the Army service, I still was interested in physical education to be a teacher, and consequently I enrolled in physical education at the University of Maryland. I stayed there for 2 years and subsequently transferred to Springfield College because I thought I would have a better education at that institution. Hence, when I graduated in 1952, the commencement speaker was Dr. Stuart Staley from the University of Illinois, who was also a Springfield graduate. He invited several of us to apply for assistantships, which I did. Consequently, I went to Illinois and was assigned to Dr. T.K. Curitan to be my thesis advisor.
Dr. Curitan was sort of a legend in his own time in terms of physical education and testing and performance. What was your experience with him, and what was that like? What role did he play?
Well, he played an important role. First of all, it is not easy to describe Dr. Curitan with a few sentences, but he was a very stimulating, intelligent, and effective teacher who I had the opportunity to take several classes with. He certainly influenced me from his classes that I was interested in fitness, and I was interested in having an opportunity to utilize my fitness background in the high schools. I also had the opportunity to work in his laboratory and to work as a statistician. So I had that as a background when I left Illinois in 1953.
And after leaving Illinois, you went and taught at the high school level?
Yes, I did. I went and taught in the high schools of Illinois for 2 years. During that time, I taught all the physical education within the school system. I also taught social studies, general science, biology, ran the noon hour program, and coached 4 varsity sports. Consequently, after 2 years, I decided I would be interested in a more academic challenge, and subsequently received an invitation from Dr. Howard Hoyman to return to the University of Illinois for a PhD program.
So when you went back to Illinois, who was your mentor?
Well, actually, Dr. Hoyman initially was my mentor, and he assigned me to do the training for the disabled students that were enrolled at the University of Illinois. During the summers, however, I had to support the family that I brought, and he provided me housing for that. So I worked for the Agriculture Extension Service in Illinois with Dr. D.M. Hall, who was director of the H aspect, the health aspect in the 4-H programs. He had a fitness program that went throughout the state, and I consequently was the individual that collected his data and helped him analyze it. And as a result, he influenced me and stimulated me to transfer to physiology to become an exercise physiologist.
Now, while at Illinois, what was your thesis, your PhD thesis topic on?
I was interested in the bradycardia of training. I was influenced by the information provided by W.R. Hess in Switzerland on the role of diencephalon. So consequently, I wanted to explore the role of the central nervous system as far as the diencephalon was concerned, and specifically the hypothalamus, and the role of the vagus nerve in the process. Hence, I had groups that were electrolytically lesioned. Actually, I tried to record initially and found that I was unsuccessful in that, so I reverted to lesions in precise areas in the diencephalon, and I also performed vagotomies on these animals. As you can see from the slide, the process of training in those animals, regardless of whatever was done to them, they exhibit the bradycardia of training. I also, at that time, injected atropine sulfate, which was an inhibitor of the cholinergic system, and found that the trained had a lower heart rate, presumably because they had more acetylcholine present in it. So as a consequence of these results, I concluded that the bradycardia of training was clearly a parasympathetic effect, and it possibly could have been done or associated with the non-neuroacetylcholine in the heart.
Now, after you finished your PhD at the University of Illinois, you took a teaching and research position at Springfield College, where you went and worked under Dr. Peter Karpovich, a renowned exercise physiologist and also apparently a rather strong personality and sort of aristocratic type of an individual. What was that like in his lab working for him at Springfield College?
Well, that was quite an experience, and like Dr. Curitin, you cannot describe him with a few sentences. He also was a complex individual who was a very intelligent and dominating personality who was outstanding in his ability to analyze data. I must say that I've never seen anyone with that capability. He also had the capability of making you feel like a prince or a peasant, depending upon the circumstances. So there were quite a few occasions where I felt in both circumstances. Subsequently, but I had the opportunity to be his research assistant and direct his laboratory, as well as teach exercise physiology to the students there. And some of the projects that I was involved with were sponsored by Alka-Seltzer for ergogenic age, and that's what you see the reflex time, the quadriceps reflex time measurements. We were fatiguing subjects, and subsequently they were to receive Alka-Seltzer to see if that minimized the fatigue process. But in the process, we learned that the reflex time, as others had shown, became much slower after exhausting fatigue, but it also became, quote, faster with really mild and brief periods of acute exercise. Another thing that we learned, which I think was a new finding, that when you did the drastic maneuver, which is done in this particular way, you have a central effect. And regardless of the level of the reflex value, it will make the reflex time faster. So we found that there's still, even though we had probably fatigue at the effector, that there still was a central drive left was present. And we were never able to separate that from the efferent activity that went to the receptors in the muscle. The other aspect that we explored with Dr. Karbovich was the influence of the electrogoniometer, which actually Karbovich invented. And this was a technique in which was used to measure limb movements, gaits in that aspect. And as the diagram shows, with its calibration, it's a Wheatstone bridge that the resistance allows you to determine the angle of the limb involved. And we use this electrogoniometer on a variety of subjects. As shown here is one study that received a tremendous amount of popularity, which was the walking in high heels, because we were able to measure the ankle joint and the knee joint with high heels. And Time magazine made a big play on that, and obviously that pleased Dr. Karbovich. But we also used it in hospitals to determine the gait patterns of different subjects with different disorders, and we could use that to determine the progress being made and the improvements. So it had a lot of potential, and it was utilized for that purpose and supported by the Surgeon General for that reason.
So essentially, your initial studies at Springfield looking at the spindle reflex was sort of a motor learning type of a study more than exercise physiology.
Yeah, that's it. But don't forget it was related to an ergogenic effect. And Karbovich is well known for his ergogenic studies. In fact, at the time when I was there, he was probably the best known person in the United States on his ergogenic insights. So it was really to see to what extent Alka-Seltzer would minimize the fatigue associated with the process. As I indicated earlier, I did not learn, or we did not study that aspect with Alka-Seltzer when I was there, but we were preliminary to that.
Now, after being at Springfield in 1963, you took a position at the University of Iowa, and that was a joint appointment in physical education and physiology and biophysics. And you were able to establish and maintain, a nationally renowned PhD training program over almost 20 years or so. Can you describe what was unique and sort of supportive about the university environment, University of Iowa environment, that enabled you to accomplish this?
Yes, I'd be pleased to do so. First of all, the idea was to establish a joint appointment between the Department of Physical Education and the Department of Physiology and Biophysics for this position. It was a joint appointment, and it may not have been the first, but it was among the first by which the Department of Physical Education was aligned with the College of Medicine department. Secondly, it was the vision of Dr. Lewis Alley that you see here on the slide. Dr. Alley had the vision that it was essential that the graduate programs in physical education have more rigor, have more demand. So as a result, we developed a program that virtually was pre-med in its requirements. So anyone coming into the graduate program had to have the chemistry, the physics, the math, the biology required for our pre-medical curriculum. After that, they then took a variety of courses equivalent to the medical students in their basic sciences. And as you see from the alignment of departments here, that virtually all of the departments that are listed, we had required courses within them. The exception being that the endocrinology was taught in zoology anyway. So as a consequence, our students became exposed to this rigorous background, and we expected them to perform. Now, I would have to say that the success of this program was not its idea. It was the students like you that made it work. And I'd like to acknowledge an example to illustrate the point. I didn't emphasize that there was a considerable amount of reluctance and skepticism by the faculty of the physiology department there that this was a very wise process or procedure. But I was able to recruit very talented students, again like yourself, who were dedicated to make it successful, and the person that I want to acknowledge was Dr. James Barnard, who probably was a James Merrifield for our program. And during his initial experiences in these courses, he not only was able to secure A's in biochemistry and physiology and a variety of other courses, pharmacology as well, but he also corrected the professors on their knowledge concerning the exercise physiology. And I think that having students like James Barnard in the initial process, he helped pave the way for the acceptance of the program by the Faculty of Medicine as well as by the graduate college as well.
Now, if you look at the list of the graduates from that program, you can see people that went on and studied in a variety of different areas, and some of the leaders in specific fields. And remember, the ground rules for this interview is you're not allowed to tell any stories about any of these students, especially not about Frank Booth. So, yeah.
Or yourself. Well, this list, the partial list, indicates some of the students that became graduates of the program. The program would not have been successful without the students, and as a consequence, if it hadn't been for their dedication, we would not have been successful. This list includes a whole host of individuals at very prominent institutions and research laboratories, not only for academia but also for the government, as yourself, and some have become not only professors, others have become deans, others have become chiefs, as you are, but also one has become a president. So they've been very successful, and I'm very proud to be associated with students that were within the program.
Now, when you began your career, who were some of the physiologists that really had a positive impact on you at the early stages?
Well, there were three actually that had a great impact on me. The first one was Robert E. Johnson at the University of Illinois. Dr. Johnson was associated with the Harvard Fatigue Laboratory. He also is credited with being responsible for the Harvard STEP test, which incidentally was part of my master's thesis at Illinois. And he was the individual who I felt was one of the most influential and intelligent persons that I've ever met. So he had a great influence on me, and he was also my teacher at Illinois, so that was a very important factor of his influence. The second is Arthur Steinhaus, who was a professor of physiology at George Williams College, but more importantly, at least in my mind, he was the author of a classic article called The Chronic Effects of Exercise that was published in 1933 in Physiological Reviews. He also came to Illinois when I was a student there, and that reinforced that this was a model that I should try to emulate and be cognizant of. The third individual that's shown there is Sid Robbins from Indiana University. Sid was the first individual to receive a PhD from the Harvard Fatigue Laboratory. And he's also probably the only student whose PhD on VO2 max of individuals throughout their various age range became a classic. Consequently, all three of these had an important effect on me becoming an exercise physiology and people that I tried to emulate during my career.
Now, once at Iowa, once you were establishing the training program, did you resume your studies trying to determine why trained individuals have a lower resting heart rate?
Yeah, I was fortunate enough to be able to continue those investigations. And I found, much to my surprise, that the effect of training was present in animals that were chemically sympathectomized and hypophysectomized, and then also thyroidectomized. I demonstrated that the presence of the sympathetic nervous system or the endocrine systems as far as the anterior pituitary is concerned was not essential for the effect. Then we concentrated on the cholinergic aspect and found that, first of all, that the trained animals did have more acetylcholine, atrial acetylcholine, than the non-trained. But we were not the first to discover that. A Czechoslovakian individual had published that previously. We also demonstrated that indeed the cholinesterase level in the heart were not a factor for the bradycardia of training. We also learned, however, that the enzymes responsible for the formation of acetylcholine, as you might expect, were increased. We also found, as you might surmise, that there was a decrease in the number muscarinic receptors. They were downregulated. And we also were able to demonstrate that the trained individuals, training would occur in virtually any animal population. So that led us to look at the isolated heart, the Langendorf preparation, as a means to determine if indeed it was the intrinsic heart rate that was changing in the animals. So we used the Langendorf preparation with a large number of animals, and as you can see, we demonstrated that indeed training did show an effect. But when we removed the heart from the animal and put him in the chamber and it acted as a volume conductor to record the heart rates, that there was no difference in intrinsic heart rates. So we dispelled that aspect. However, there's one aspect that does remain that we have to acknowledge, and that is in the isolated heart perfused preparation, we did find that the response to atropine was similar. We did find that the response to beta blockers and neostigmine, the cholinergic agonist, was increased. So we came to the conclusion that by whatever mechanisms, the heart has more acetylcholine and less norepinephrine as a result. So hence, we've come to the conclusion, or at this stage, that it's not the intrinsic heart rate, but that trained animals, because probably of the availability of the parasympathetic nervous system, have more acetylcholine and less norepinephrine at the SA node.
Before we go on and discuss some of the other studies that you undertook at Iowa, can you give us some information on the Iowa wrestling studies? And this was sort of a series of studies over many years, wide notoriety, and involved a lot of aspects of these high school or scholastic wrestlers in terms of they're trying to make weight to compete. I mean, you dealt with the issues of how much weight was lost, you dealt with the prediction of a minimal body weight, the issue of dehydration came in, weight classification system, so it was a multifaceted approach. Can you give us some of the background and history on this Iowa wrestling study?
Yes, I'd be pleased to, and this slide shows the importance of wrestling to Iowa medicine and to Iowa, and like its corn, wrestling is extremely important to the state of Iowa. It happened in 1967. A small medical society in Muscatine County, Iowa, because of their pre-wrestling exams, came to the conclusion that wrestling was a health hazard because of the practices that the individuals in Muscatine County were following to make weight, to be certified. So they passed a resolution and publicized a resolution that it should be outlawed. That had a tremendous effect on the state. And it also had an influence, or is there a way to resolve this problem? So as a consequence, we began to study what was the problem. What was the magnitude of the problem? So we visited 30 high schools and took measurements or secured measurements of 747 wrestlers that you see in the slide. Now, the weight loss being demonstrated in this slide was recorded in 17 days. However, in 12 high schools involving several hundred wrestlers, we went back and examined the weight loss. And we found at 10 days, after 10 days or 7 days before this 17-day period, there was no change in weight. So these individuals that you see listed here lost that period of 5.5% of their body weight, 6.8 pounds, in 7 days. We also found that it was the lightest individuals, the youngest individuals that were losing the weight. So as a consequence, we felt that there was a definite need to come to a method to resolve this practice of making weight. Therefore, we began to see how did they make weight? And as a result, we began to examine state finalists. And as this slide shows, we went to the state finalists to examine how some of their characteristics, particularly with the urinalysis. And this is your study. So why don't you tell us what really happened as a result of your study with these 60 finalists at the state finals?
Well, as you mentioned, you found that they were losing a large amount of weight. It was occurring over a short time period. And what you didn't mention was that their body fats were not changing. And so we knew they were dehydrating, but we didn't know how to quantitate that. So as shown, we simply looked at the urinary profile of the wrestlers just before they went to weigh in, compared them with normal high school students, and every indication from the urinary chemical composition showed that they were dehydrated, and it looked like they hadn't had any liquid for about 3 days or so. So it really confirmed what we knew what was going on. What about the aspect of the prediction of what would be the ideal weight for a wrestler?
Well, that's a good question, and that's where I fall back on my experiences with the 4-H clubs. Dr. Hall had measured around 15,000 4-H club members in Illinois. And as a result, he developed a predicted fit weight. And that predicted weight was determined from anthropometric measurements that demonstrates on the card, such as the height, the knee width, the hip width, chest width and depth, and thigh circumference. And he had that in prediction equation. And he had it, again, as I alluded to, between about 15,000 subjects. So we invited 30 high schools to send representatives to try to see if the Hall method of predicting weight was suitable for these wrestlers. And these individuals came to Iowa City and became trained, as this slide indicates. And once they went back to their high schools, they made the measurements, supported by the Iowa Medical Society and the High School Iowa Athletic Association. They made the measurements, sent us the data, and we evaluated whether the Hall method prediction equation was going to be suitable for use for the Iowa wrestlers. As this slide shows, that the method advocated by Hall, even though it had extremely high correlation, it overpredicted the heavier groups and it underpredicted the lighter groups. As a result, we came to the conclusion that the Hall method could not be utilized. And I say that because the president of the Iowa Medical Society advised me to encourage the use of the Hall method for the wrestlers because they were receptive to accepting any formula. But we decided we would not and would have to get our own data. Now there's a point here that, and it was an important lesson for me, we did not have the right population to use an equation, to predict equation. We needed to get a population of wrestlers and develop an equation from that population and then determine whether it could produce a predicted minimum weight. And that's what we did. And in fact, you were a part of this. We went to 50 high schools, measured over 800 wrestlers, and sent that data to be analyzed to determine whether our prediction equation, which was called the Chang, who was a doctor candidate at that time, the Chang-Tipton formula for a minimal predicted weight, wrestling weight, would be effective. It had a high correlation, was cross-validated, and it seemed to be effective for wrestlers in Iowa. Unfortunately, for whatever reason, the Iowa High School Athletic Association, Interscholastic High School Association, did not accept it. So as a consequence, we decided, well, we better go on a national level, and we went to the Midwest regions, and we involved 5 states and investigators from 5 states. So we collected data from 860 wrestlers. Now, the unique feature of this data, we had 19 different anthropometric measurements, and we also had underwater weighing to determine body density. So with this data, we then began to analyze what equation would be suitable to predict a minimal wrestling weight. We came out with the equation. It wasn't just importantly, it wasn't the Chang-Tipton equation, but it was the Lohmann equation on skin folds, which had the least amount of error. And as a result, we recommended that the Lohmann equation be used by state athletic associations to implement a minimum body weight, which was approximately, we estimated it should be 7% fat. Originally, we started with 5%. We thought with the younger population, 7% should be the lowest limit weight. So that's what we did. We recommended it, and no state adopted it except one, or used it, and that was Wisconsin. And Wisconsin accepted the idea and had a 2-year trial system. What Wisconsin did that was different from what Iowa had tried to do with the high school non-coaches coming to be measured was they utilized certified athletic trainers. And as a result, these athletic trainers took the measurements, and with the use of the Lohmann equation, they were able to determine that this equation would work for them. After a 2-year trial period, they recommended it be mandated for the state of Wisconsin, which it was, and that was in 1991. About 5 years later, the National Federation of High School Associations recommended that states consider some kind of weight prediction formula for minimal wrestling weight that considered 7%. However, 1 year later, after their recommendation, we had 3 collegiate wrestlers die of dehydration. So the National Federation came back with a recommendation that they should implement such a program in 2005, and it was implemented at that time. Although the equation being used is not likely to be the Lohmann equation, which was validated by our previous research.
So this project really involved almost 30 years of scientific research. You know, I wonder whether or not the importance of it was not so much the science that we provided, but rather the awareness and education and sensitization to the coaches and the wrestlers in terms of how to do it smart, the problems of weight loss.
Well, I think that's a very astute point. I was thinking about that particular aspect, and when I started in 1967, I thought the process would take me 2 years at the most. So 30-some years later, there's now a minimal wrestling weight for 265,000 wrestlers in the United States. So I think what you've just mentioned is the reason why it took so long. It wasn't the science that it convinced them, it was the education that it convinced them, coupled with a tragic death.
If we move on to some other aspects of science, particularly your science, most people in their careers specialize either in one particular area or maybe 3 or 4 areas. But if we look, and as I think you're going to illustrate, you were really active in a wide variety of areas. What's different about Tipton versus most of the people?
Well, that's a tough question. I think that the simplest answer is that I'm probably the last of the generalists. And nowadays everybody specializes, but I was interested in the question being raised and the fact that I couldn't answer them, and as a result I became interested in the project. But the underlying aspect of all these projects that I've been involved in is what are the contributions from exercise in itself? What are the mechanisms associated with exercise, and how is exercise important in solving this particular problem? And I think for that reason, I became involved in a whole variety of projects that we'll talk to some extent about.
Can you start by going into some of your studies on ligament properties?
Yeah, it was connective tissue, and it was to answer a question raised many years ago by Karpovich, a question to Karpovich: why would deep knee bends be outlawed because they weaken ligaments? And there was a group in Texas that outlawed deep knee bends because it weakened ligaments. So I began to look at the evidence for that, and there was none. In fact, there's the best evidence that what happened to ligaments with exercise was obtained with the sand bucket method, where you added sand to a bucket, put a wire around a ligament of a rabbit, and when the ligament tore away from its insertion site, that was its strength measure. So as a result, we developed a measuring process. It's really a stress-strain relationship with the ligaments, and developed the equipment that you see to the left that can quantify the response, the stress and the strain. Moreover, it can be done in situ preparation, so that gives it a different advantage than just an isolated preparation. But we found that indeed it was a result that infected most of the ligaments at the insertion site or the junction, and hence we called it the junction strength. And fact is that you have to consider the insertion site, which involves the ligament, mineralized fibrocartilage, and bone. And so as a consequence, we called it junction strength, and we measured the forces required to separate the ligaments from its insertion site.
How did that change with things like exercise training or aging?
Well, first of all, the slide indicates the effect with age, and it increases with age, with time. The interesting thing about the change is that it's related predominantly or extensively to the mass of the animal. For that reason, males are stronger, male animals, and particularly rats, are stronger than, quotes, females. But if you look at on a relative basis, a force per unit body mass, that females are stronger. So as a consequence, we came to the conclusion that you had to evaluate it on a body weight ratio rather than on an absolute ratio. And we sort of proved that with this next slide, which indicated if you had pair-weighted animals or non-pair weighted. The slide to my left, or to the left of the camera, is the situation where the body weights were similar, but strengths were different, and the strengths were different also on an absolute basis, but they were also different on a body weight ratio. The slide on the right shows what happens with the when you have non-pair weight. The difference still exists when you express it on a body weight. So that convinced us we should express our results on that relationship. The slide with dogs demonstrates, I won't go into the various groups, but it demonstrates from the left to the right that the more activity that a dog is involved with, it will have stronger junction strength. And that's the whole purpose of that slide, and I'll mention other aspects later on.
Now you also looked at exercise training and ligament and junction strength, correct?
Yeah, well that was some of that, but we also looked at immobilization, and that was quite enlightening, because when we found with immobilization, first if you look at rats, that indeed the junction strength is lower. Now part of that reason is because of what we see in the middle indicates that if you look at the isolated ligament, the ligament atrophies. So immobilization causes atrophy not only of the junction, it causes atrophy of the bone and the mineralized fibers. It also causes atrophy of the ligament per se. And that's demonstrated if you look at its wet weight, which is in the middle, or you look at its dry weight. That ligament is really altered as well as the junction. And the same thing happens with the dogs. Down here in the yellow is what happens with immobilized, and as you change the animal activity profile, whether it's standing or exercise, the point to getting that the more exercise, the stronger the ligament. But immobilization is deleterious to connective tissue and its junctions.
Now, my recollection is that people used to think that ligaments were sort of inert metabolically, but didn't you do some studies to actually sort of address this issue?
Very much so. In fact, we believe that. We believe that a statement that was in very many biochemistry textbooks that ligaments and connective and tendons were metabolically inert. So with the aid of a talented graduate student named Arthur Vallet, we measured the aerobic capacity of the tissue, measuring cytochrome oxidase levels. And as this slide indicates, that indeed aerobic capacity is low, but it's not inert. That is not a medically inert tissue. We also measured blood flow, and it was low, but there is blood flow in these tissues. What this slide demonstrated dramatically is that like muscle, ligaments and tendons with immobilizations become very, very less metabolic. Metabolic activity is decreased, and it's having a tremendous effect, immobilization, on the metabolic profile of these tissue, regardless of what level it is to begin with.
Now, when you talk about immobilization, and if you're talking about sort of repair and recovery, what did you learn about the sort of the time course of these things?
Well, that's certainly an important question, and certainly one that clinicians, orthopedic surgeons, and I had a very good relationship with orthopedic surgeons at Iowa, and as a consequence, we collaborated. And what I have shown in this particular slide is what I call the wisdom of the dog. And the fact is that if you immobilize a repaired ligament, that ligament is going to be weak, period. On the other hand, if you repair a ligament and do not immobilize the dog's limb, that ligament will still be weak, but it will be stronger than it would have been if it had been mobilized. The dog is smart enough, and I believe the same has been done from human, that it will not utilize that limb to be a problem. And as this slide demonstrates, a non-mobilized repaired ligament, leg of a dog, is not as weak as it would have been if it was immobilized. And the bottom slide, it indicates the effect of time and exercise on repaired strength. And to the lower left is the effect of 3 weeks of immobilization. Then we go up in 3-week intervals, and we find that the ligament, with time, repaired ligament becomes stronger. You take the cast off and just return it to the cage, it becomes stronger. But if you exercise it, it becomes even stronger. On the last slide, the last one that is shown there, is that the exercise training of that, doing mild exercise, increasing activity, increasing motion, the ligament becomes stronger. But it doesn't become back to normal. It's going to take a long time for that to occur.
So essentially, a lot of these studies with a long time course, months, many months of time to recover, this also is consistent with a new way that they're treating knee injuries. I remember back when a person had knee surgery, all right, they put the leg in a cast, and then there was a long time recovery, whereas now it's a matter of wrapping it in an ACE bandage and loading it as much as pain permits.
That's very true, and we did some isolated ligament studies to sort of set the stage for this, and this slide demonstrates the point you just raised. But the concept that you just mentioned is somewhat the concept behind constant passive motion of individuals undergoing surgery at the present time. And the original concept came from, I think, from Agassiz, where he showed, first of all, the profile of what happens with immobilization and recovery, which is reduced. But if you add surgical repair to the process, it's going to take an even longer time for recovery. The bottom line is this, that a repaired ligament needs motion. It does not need immobilization, and it will take a long time for recovery to occur. The clinical aspect, from my perspective, is that clinicians should advise people who have repaired ligaments that they cannot return to competition in the time frame that they would like to, but they're going to be dependent, and as a benchmark, I say anyway, that you should wait about a year after you have a repaired tissue to return to competition.
Moving on to a different area, over the years you've been very interested in endocrine control of changes with training and adaptations, and you applied some techniques and all that perhaps traditional endocrinologists would have applied, but you used it in the exercise training setting. Can you describe some of those studies?
What we want to demonstrate is to what influence are hormones on the exercise response. And the traditional way is to remove the hormone or replace the hormone and try to determine. So we reverted to the thyroidectomized, the hypophysectomized, the adrenalectomized in combination, so forth, and used that approach to see if we eliminated the hormone or even replaced the hormone, to what extent was that determining the exercise response, and to what extent did that really have an influence on the responsible mechanism. The study that I take great pride in, it's really done by Woodman, is that if you take a hypophysectomized animal and use the most important measurement in exercise physiology, which to me is oxygen consumption. And you train these animals after they have been surgically hypophysectomized. You can demonstrate, as this slide indicates, that even with the removal of the hypophysis, the anterior pituitary region, that these animals can become, first of all, you normalize the values, and secondly, you can improve the training effect. So training can occur in the absence of these anterior pituitary hormones. And to me, that's an important concept.
Along the way, you started to investigate the effect of exercise training on cardiovascular function, and there are a wide array of studies. Could we go through some of these briefly?
I'd be pleased to do that. The question that was addressed to me was by Michael Brody in the Department of Pharmacology, who said, what was the evidence on the effect of exercise training on hypertensive animals? And in fact, normotensive as well. So we initiated the studies, and at the time we were doing studies with bush babies in ligaments, so we converted them and measured their exercise response using caudal artery as our measurement, systolic blood pressure measurements.
Now these bush babies are subhuman primates.
That's right. And we found that they were sort of borderline hypertension, that we could lower blood pressure, systolic blood pressure, by approximately 10 millimeters of mercury. Then we investigated the normotensive animals associated with the Sprague Dollies and also the WKYs, which are the controls for the genetic. And we found that we could normalize those animals. Their pressures are lowered. They were all normal, but we can lower normal blood pressure by about 8 to 10, maybe 12 millimeters of mercury. So therefore, we began to study the question that he really asked me about. What about hypertensive animals? And so we used the conventional method of more exercise is better, higher the intensity, and much to our surprise, we found that if we increase the intensity higher than 75% VO2 max, we increased blood pressure. It was strenuous. It was undesirable. It was deleterious. So we had to modify our concept of training for hypertensive animals and make it 40 to 60%. We also found that with dull hypertensive rats and renal hypertension, we could not lower them. We don't know why, and no one has followed up on that as to explain why, and perhaps after this is over, you can tell me what I should know. But we did show that with medication, reserpine, hydralazine, chlorothiazide, with 85% of the medication plus training, we can normalize blood pressure, indicating that indeed there may be a great advantage for individuals on beta blockers. You need less medication. We also demonstrated, which was interesting to me, that if we chemically sympathectomize a hypertensive animal virtually at birth, we can normalize blood pressure. But more important, or equally important, at least to me, that training of a chemically sympathectomized SHR animal can lower it as well, indicating again that training in itself will have an impact on the organism independently of these other components.
Now, when you say training, you're introducing a whole new aspect here in terms of intensity of exercise, particularly in a rat model, by using a percent of VO2 max. I mean, how did you actually measure the intensity of exercise in this rodent exercising model?
Well, we were not the first, but we were probably the first to really utilize it for prescription purposes. We built a chamber, a red mount chamber, that currently is similar to, or let me say, the one that the Columbus Instruments are now using is similar to the one that we built many years ago. And we use that to not only to quantify the exercise prescription, but we also use that to indicate the level of the trained state. And as a consequence, it's been very valuable and an essential component in our research procedures. The thing that we found with the hypertensive rats, and it's really funny, that when we exercised them, we found that light into moderate exercise would increase cardiac output using microspheres. On the other hand, if you increase the intensity up to 75% with heavy exercise, that the cardiac output was decreased. So as a result, we found that indeed it appeared that heavy exercise was responsible for a decrease in stroke volume, and also possibly responsible for the decrease in VO2 max that we'll talk about subsequently. But for resting state, the resting state is associated with a reduction in cardiac output and an increase in total peripheral resistance, just the opposite of what we expected.
You also did some, aside from using aerobic exercise or treadmill exercise, you also did some studies looking at resistance exercise in a rodent model. Can you explain those studies?
Yes, very happy to do so. First of all, when we talk about stroke-prone animals, we have to realize several things. First of all, their lifespan is going to be less than the normal. And the normal SHR, if that can be considered, which is about 1.5 years. The lifespan of a stroke-prone SHR is less than 1 year. Secondly, they call it a stroke-prone because the animal ostensibly dies because of a stroke. But we found that that wasn't always the case. We found that 83% would have subjective measures for a stroke, but only histologically we could prove it in about 48 to 56%. Which means that investigators using stroke-prone animals cannot assume that their death is due to a stroke, and they should prove that the death was due to stroke. But anyway, we did that study that's being listed here, and we found that with older animals, about 4-month animals, and we trained them at 40 to 6%, the hypothesis was to see would blood pressure be increased and would the results of stroke occur. We found for 40 days we could lower blood pressure, but only for 40 days of a 100-day experiment. After that, the blood pressures were similar. When we looked at the strokes using cerebrovascular lesions as determined by a pathologist, we found that not all the animals, as I alluded to, died of strokes. But the ones that did die of strokes, we found that indeed it suggested that strokes were increased in the ones that exercised. So the amount of aerobic exercise seemed to be an inducement for strokes. So that really led us to examine what happens with other types of exercises.
What other types did you look at?
We looked at static exercises. And we looked at static exercises because we were led to believe, as many heart associations were advocating, that pressure responses from isometric exercises was dangerous because it elevated the pressure and also was potentially dangerous for a stroke. So we took the stroke-prone model and put them in a version model, a training model in which they avoided hanging over a grid when a sound or a light occurred. We trained them with jackets on. We put jackets and weight on it, and we had them hang with either 6 to 20% of their body weight and follow different sets of weight hanging. We found that indeed this increased the hanging process, increased the blood pressure by 70 millimeters of mercury, increased the heart rate about 115 beats per minute, decreased Doppler blood flow to mesenteric flow by 70%. So we knew, and we also had EMG activity on the biceps, so we knew that it was effective exercise. But as the last slide shows, we could not show with these stroke-prone animals over a 20-week period would increase blood pressure. So isometric static exercise in this model did not increase blood pressure. Also, we did not show an increase in strokes, which we had predicted. Now, the only thing that we can say from this, or that we've mentioned, is that we believe, obviously more study is needed, but we believe that heart associations should be a little more cautious and maybe not so dogmatic about pressure, isometric exercise, weightlifting, and combinations which do have static components to prevent them from doing that. We believe that they should be performed, but not at maximal levels.
One of the last studies that I recall involved the issue of cardiac hypertrophy. And we know we have disease hypertrophy of the heart, which is deleterious. We know we have exercise causes hypertrophy. Didn't you do some studies putting these two things together?
Yes, we did. And in fact, the SHR is a good model to study that. And first of all, as a slide to the left indicates, that hypertrophy does occur with normotensive, moderately hypertensive, and severe hypertension, which is over 200 millimeters of mercury. And we found that indeed hypertrophy occurs. Now, we weren't sure whether it was pathological hypertrophy, and we're not certain that we can demonstrate that, but we did look at the change in capillarization. The slide to the right demonstrates that indeed the normotensive animals had more capillaries. We did increase that. The moderate hypertensive increased their capillarization, but we could not demonstrate that with the severe hypertension. So that probably rarefaction occurs. So it's possible that we were close to a pathological state, but we can't prove that from our measurements. It's just suggestive.
If we go on to a different topic, as you evolved, and particularly as you transferred to Arizona, you got involved in some studies on microgravity. Can you sort of brief us on some of those?
I got interested in this for two reasons. First, I was appointed to a study section for microgravity. And secondly, Dr. Hargens, Golnick, myself, and Ankerson had submitted a grant to NASA to study the effect of head-down tilt on fluid movements and on loss of muscle mass. And they rejected us. And we think that we were rejected in part because we wanted to do biopsies. So we did the study anyway. So we looked at interstitial fluid changes, and we looked at water content of muscles and combinations. So that got us started. We also knew that the head-down tilt not only caused muscle atrophy and fluid shifts, but it had a lot of other components involved in the process. So we designed a means by which the lordosis of the animal with tail suspension that you see on the right here was followed. Consequently, we conducted a study and with the tail suspension, and the list here indicates some of the results that we found. Now, we demonstrated, as others have shown, that indeed there was massive atrophy, particularly in the type 1 muscle. We also showed, I think for the first time, that blood pressure, contrary to what was expectation, did increase. Heart rate, likewise, didn't seem to show much. But the most important findings, unexpected finding, was that we found that the temperature regulating system, the colonic temperature, was decreased. And that, to us, is an area that we feel has been ignored and should be pursued, particularly in astronauts and cosmonauts, and we are hopeful that will be indicated in the future. What we also did was to, and I think for the first time, is to use our oxygen consumption unit to determine to what effect was VO2 decreased, and we found, and this was Overton's study, was decreased about 11-12% over a short period of time. So oxygen consumption was decreased associated with this particular procedure. As you might surmise, we tried this out on hypophosectomized animals, so the hormones. And you can see the staircase effect occurring with this process. And that was associated with a decrease in mechanical efficiency of running as well. The study that I alluded to earlier, it was demonstrated here that indeed with maximal exercise, a suspended animal is going to show a reduction in cardiac output. This slide doesn't show, but we also demonstrated with heavy exercise, not only you have a reduction in stroke volume, which probably accounts for the reduction in VO2 max, you have a shift in metabolism. We had incredible increases in lactic acid levels with the heavy exercise, and we also found hypercapnia rather extensive as well. Obviously, acidosis was prevalent as well. One of the things that we did with suspension that I'd like to mention is the use of the one-legged model, as you see on the slide. And that slide demonstrates that if you can use a one-legged model, and we use a one-legged model and added 20% of the body weight to that, in which we have weight bearing. Now that is important because Alfred showed years before this that the electrical activity, the efferent activity to the muscle was decreased for as long as a week. So we wanted to know whether if we had weight bearing with a one-legged model, could we prevent that? And secondly, what would that effect have on the muscle mass? And as the slide below shows, that indeed with suspension, that one-legged, the non-supported legged, had a decrease in electrical activity, but the weight-bearing leg, it returned. Also returned was that with weight-bearing, the muscle atrophy in the soleus was the same as the non-weight-bearing limb. It's the same as a non-weight-bearing limb. But the effect on the other muscles wasn't like it was on the soleus. It did not prevent the changes we saw in these mixed muscles, and it had no effect whatsoever on aerobic capacity of the muscle.
Tip, I want to thank you for reviewing the wide number of different types of studies that you've undertaken. You clearly are an effective generalist. In looking back, of all those different studies, which ones do you find sort of the most rewarding?
Well, that's a tough question, which I've been thinking about. First of all, as I alluded to earlier, I've really been interested in learning to what extent is the exercise response or the training response modulated by neural or endocrine or sympathetic factors. So I'd have to relate to those studies that related to hypophysectomized or adrenalectomized or sympathectomized animals as the ones that gave me the most pleasure. First of all, I was led to believe from reading Turner that if you exercised a hypophysectomized animal, it would die. In fact, you weren't in that class, but I had an experiment back in Iowa where I wanted to demonstrate that point conclusively, that these animals would die if they exercised because they didn't have any pituitary hormones, anterior pituitary hormones. And after 2 hours and have students watching these animals still exercise, and I was convinced that he was wrong. So I think that was an impetus for me to be concerned about to what extent are these components, the neural components, the sympathectomized components, the endocrine components in exercise. And I'd have to put those as the ones that I take the greatest satisfaction in.
Now that you've retired, those of us that know you know that you're still engaged. In some of the activities that you're doing, what do you find the most important, or what's your priority now?
Well, first of all, leaving the laboratory and not having the students is not an easy thing to adjust to or accept, because those are great pleasures. But what I have done and been interested in is the history of exercise physiology and the history of physiology section of APS. So as a consequence, I've been involved with their activities, but I've also been concerned about the antiquity of exercise. And contrary to what we were led to believe, that it began with the Greek and Roman era, that's not correct. It began back with the Indus River civilizations before the Greeks and Roman with India. So as a consequence, I have been pursuing the antiquity of exercise in more detail and wish to pursue that as well. And in fact, the picture shown here of Suruta is one person that I think may be called the father of exercise physiology and not Galen. Whether that will be accepted, time will tell. But that's one of the aspects that is currently keeping me interested at the present time.
Earlier, you gave us a list and showed some pictures of some of the mentors and role models. As your career progressed, who were some of the individuals that sort of had an ever-impacting effect on what you did and what you thought?
Well, I have a picture here of individuals that I think throughout my career have been influential in a variety of ways and have influenced me far more than I can adequately describe. I'm sorry that I didn't have a picture of George Brooks, because I think he's been a tremendous influence on my career as well in my thinking. But without reiterating their names, the list that you see here was that the majority attended a conference on exercise physiology at Penn State in 1978. And at that time we were attempting to lay out the guidelines for exercise physiology and its development. It never materialized, but the group that was assembled, I think, are the group that I think have influenced me the most.
One of the standard questions that we like to always hear from a senior physiologist is, what advice would you give to a person either starting or considering a career as a research scientist in the area of physiology?
Well, that's a difficult question, and one that I've been reflecting about. For the beginning graduate student or the beginning PhD student, I think you have to get the most rigorous education you can, and you should insist on it, and you should not start it unless it is rigorous. As far as the postdoctoral experience, I don't think you should obtain the same experiences that you had for your career. You should find another area that you're interested in with a different investigator from your own institution. So I don't believe in having postdoctorals being performed at the same institution. But in doing so, I think you need to find a postdoctoral experience in the area that you like with an individual who's really interested in you, rather than in having you promote and advance their careers. So I think it's very crucial that you follow that advice in selecting the postdoctoral experience. After the postdoctoral experience, I think it's important that you go to a position not for its location but for its opportunity. And the one caveat that I would advise individuals is that institution interested in seeing that you develop as a physiologist, or is that institution just really concerned about filling a void in their program, and whether you're that person just to fill that void, I'd be clear about. And last but not least, I was told by Lewis Alley to always look at the chairman, and is he interested in you, and do you believe in him or her? And I think that's good advice.
Do you think a person can survive as a generalist versus a specialist in this?
I'm probably the last of a dying breed. I don't think so at all. I think you have to be a specialist. You have to be competent in molecular biology, and you need to specialize because, first of all, the grants support is for specialists, and departments are hiring specialists. So no, the day of the generalist is gone.
In terms of the advancement of physiology as a discipline, what advice or input would you give to the American Physiological Society or the Council?
Well, I spent 3 years on the Council, and they didn't take my advice then, and I'm not so sure that they would take it again. But here's the position I would offer. The American Physiological Society is a society devoted to research and investigators performing research. Therefore, I think that our society, because it has really outstanding and extensive reserves, should re-examine how much reserves do you really need and reduce that amount to what is essential and use the difference to support beginning investigators to become physiologists so they can promote the profession. And even though the numbers may be small, I think that is the better use of our reserves than just having reserves that are impressive and large but not contributing to the advancement of the profession.
On behalf of the American Physiological Society Living History Program, I want to thank you for taking the time for enlightening us in terms of some of your activities. I know I enjoyed it, I learned a lot, and I'm sure others who don't know you as well will appreciate the contributions you've made. Thank you very much.
Thank you. It's been my pleasure.